All right, the rate at which people seem to be joining us is slowing down, so I am going to go ahead and get things started. Thank you all for joining us today. My name is Chris Miller. I'm the director of the Brain Injury Services Coordination Unit here at Virginia's Department for Aging and Rehabilitative Services. We're really impressed with, although I can't say we're surprised by the interest in understanding more about finding and using data, so thank you all for being here with us. In 2018, as part of our federal traumatic brain injury grant from the Administration for Community Living, we contracted with the Virginia Commonwealth University Traumatic Brain Injury Model System through the Commonwealth Neurotrauma Initiative Trust Fund. That's a lot of words, a lot of acronyms. To begin development of a comprehensive brain injury data plan for Virginia. We're proud to show you today's presentation as a result of that work. You'll be meeting our two presenters in just a moment, but I do want to acknowledge the work of the original researchers, Dr. Jeffrey Krautzer, former director of the VCU TBI Model Systems of Care, and Jennifer Marwitz, former associate professor at VCU in the Department of Physical Medicine and Rehabilitation. And now it's my pleasure to turn things over to our commissioner, Kathy Hayfield, who will welcome you and introduce the panelists. Hayfield.
Thank you, Chris. Hello and welcome. So nice to have you all with us today. The fact that we have such a large and diverse group shows that people living with a brain injury access many components of the service system, and that talking to each other is critical. So I'm delighted to have people from Virginia and from all across the country as well. Acknowledging this reality that we all work with folks with brain injury and need to talk more, DARS sought a way to better understand these overlaps and how to use them to improve access to services for brain injury survivors. As such, the team at VCU has been working to identify brain injury data sources in Virginia and help us develop a plan to use that shared data to increase services and their effectiveness, and ultimately to improve the quality of life for people living with brain injury. Today, they're going to share with you what they've learned so far. We hope it will help you think more about how you use data in collaboration with your many partners, whether it's directed at people living with brain injury or for other purposes. I am very pleased today to introduce our presenters, and they are Dr. Amal Carmarker. He is a professor in the Department of Physical Medicine and Rehabilitation, the School of Medicine at Virginia Commonwealth University. He is also the Director of Research at Sheltering Arms Institute, a wonderful collaboration between VCU and Sheltering Arms. Dr. Carmarker is a health services and health policy researcher. He's clinically trained as an occupational therapist with advanced training in public health and epidemiology. He focuses on the utilization of health services in acute, post-acute, and community-based settings, and the outcomes related to receipt of these services. Since we're talking about data, let me share that he regularly uses Medicare, Medicaid, commercial claims, and electronic health records for his research. Also with us today is Laura Albert. Laura graduated with honors from the University of Virginia with a degree in cognitive science. Post-graduation, Laura joined the VCU team as a research assistant in the Department of Physical Medicine and Rehabilitation. And there she currently supports 5 studies for people living with brain injuries, as well as working with their families. Ms. Albert manages the website development and quarterly newsletters for the VCU TBI Model Systems. So with that, thank you, Dr. Carmarker and Ms. Albert. Take it away.
Thank you, Commissioner Hayfield. We really appreciate that kind introduction, and also for the opportunity to present our work as part of the contract. We also want to thank both Chris Miller and Donna Cantrell from the brain injury unit at DARS. And the work that we have been doing with them, it's like really amazing and has resulted into several initiatives, and one that we'll be doing this afternoon. And I also like to welcome everyone who is able to join us today for this webinar. It's always good to see so many familiar names and as part of the attendee. So we really appreciate you spending some time with us this afternoon. So we have no financial disclosure. As Chris mentioned before, this work is supported by a contract through DARS to our brain injury or our TBI model system at VCU. As Chris mentioned, this work actually was really initiated by two of our faculty members, Jeff Kreutzer and Jenny Marwitz. And I think the credit really goes to them to really set this program to where we were able to do a lot of good things. I basically got involved in the program a little over a year back, and I think we are able to produce a lot of good material and a lot of dissemination related stuff which is coming out from this contract. So this is kind of a presentation outline that we will be following. I mean, just a couple of things, even though our title has data mentioned or listed 2 times, we won't be doing any deeper dive or deep dive into any particular data set. And the reason behind that is really to provide kind of an overview of what we have been doing so far and where we are heading next. And also, this is kind of an opportunity for us to share with you some of the other resources that that are either anchored to VCU or our VA system, which actually has a tremendous amount of data and wealth of information to really look at how individuals with brain injury, how do they access care and some of the health outcomes. We'll be also talking about the social determinants of health, which is basically really an important aspect. And basically we'll have, I would say, at least like 20 to 30 minutes for question and answer, because the whole purpose of this webinar is really to engage everyone who is participating and basically share their input in terms of like how they are using data, what are some of the initiatives that are happening in different units and different departments across the country. So as I said, the discussion and question and answer component is really critical, and we have made sure that there is adequate time to basically get into that.
Dr. Carmarker, this is Chris. I apologize for interrupting. We're trying to get the screen so that people can see it better. Can you just give us one moment?
Sure.
Okie dokie. It's working now? Okay. All right. Sounds good. Thank you.
All right.
All yours, Carmarker.
Thanks, Chris. Appreciate it. So these are like, typically in a presentation, we usually have these pointers all the way towards the end. But for this particular webinar, I wanted to actually have these right in the beginning, because as we are going through the slides and talking about some of the data resources and the things that we have done, I really want everyone to think about why you think use of data is really important. And again, I think you can really think about all these questions in your context or the work that you are doing with brain injury or some other population. How are you achieving that? And really kind of how are you engaging other stakeholder in that process? And to us, as part of this contract and the work that we have been doing with DARS, I mean, this has become like a focal point or the critical aspect of everything, like how we are engaging with other stakeholder, both in terms of the work that we are doing, as well as some of the dissemination process. So think about that as well. I would also like you to think about what are some of the resources that you currently have, and maybe also think about some of the barriers you currently encounter, and maybe a positive twist to this will be like, maybe what are some of the opportunities that you think where changes can be made, and where are you heading to? I mean, as an organization or a particular unit, what are your plans in terms of near future, in terms of like utilizing the data and some of these resources to really generate the evidence, to really accelerate the dissemination process and things like that. So as I said, like think about these things as we are going through the slides, and hopefully we'll have a very productive discussion and Q&A session at the end. So the next few slides, we just wanted to set a premise, which is what do we have right now, and what are we missing? And obviously this is kind of something you must have seen. The National Institute of Health started the initiative of a big data to knowledge about 10 years back, and now it's a data science. And as part of that really has evolved, or that has really helped a lot of academic researchers, such as myself, to really think about a sophisticated way of utilizing data, analyzing the data and things like that. However, the question that I want to pose here is, what is really missing in this? And I guess the answer would be it's really kind of engagement of all the stakeholders that I have described earlier, and how are we engaging them in terms of like coming up with a study design, coming up with a clinical or a research question that is really meaningful for the patient population that we are working with. And also like in terms of like, the dissemination effort, the evidence or the knowledge that we are producing as part of all this progress that we have made. Are we really translating that back to clinical care? Are we really translating back to like say policy in terms of like advocating for access to care and things like that for individuals with disability? So I guess I think my answer would be that is what we are missing, is really the engagement of stakeholder and several entities in this particular journey. I also want you to think about data as a tool, and I think this is something like this is a mistake I have made in early part of my academic career, where I used to think that, hey, as long as you present data, it's objective, hard evidence, and you don't have to like say anything, right? I mean, I think the data can speak to itself, and I think I was completely wrong. I think because the data or the results you produce, yeah, I mean that they are certainly objective evidence, but that they are just a tool, or they are just part of a puzzle that you are trying to solve. I think what is really important, again, going back to how you are engaging with other stakeholders, how they are participating in that process, whether the stuff you are conveying, are they like actively listening? That means, are they really providing their feedback and things like that for you to help, or for you to make that process a little bit better, and make the dissemination effort even more productive and even more meaningful. So again, as I said, like really think about this, the data as a tool in the large scheme of things. The third premise that we really want to make here, which is really critical one, is none of us operate in a vacuum. So obviously, everything that goes around really impacts the way we think, the way we respond. It affects our health. It affects our outcomes, and it's the same for individuals with disabilities, brain injury or spinal cord injury, or other conditions. And so really think about this is like with all the stuff that is happening, and we used to call them like a natural experiments, right? So basically, there is a particular health policies in place, and that is really impacting the access and utilization of services and things like that. However, more recently, I started thinking about these as kind of a multi-layered or kind of a multi-tiered natural experiments. And obviously, COVID-19 pandemic is probably like one of those examples where so much disruption has happened, both in terms of the personal well-being, access to some of these services, and outcomes. So really think about that, all these things that is happening, as part of the natural experiments, which are kind of layered, which are layered, and again, like think about the data that is coming out from that, and how we should be interpreting it. I think one of the things I would also like to caution is like, even though all these things are there, I mean, no data is perfect. However, it's really important to acknowledge the limitation, and really important to acknowledge the interpretation of the findings in the context of everything that is happening in this day and age. I think one of the things I would also like to mention is some of the social issues that we as a society has been dealing with for the past couple of years. And obviously, when we think about the social determinants of health, some of the disparities and equity type of issues, those things are really important to take into account as we look at the data and the evidence that is coming out from that. So I think we would like to like shift a little bit and set up the stage, just so that we understand like what are some of the different data categories that we are thinking about, or that we are talking about. And obviously that list is pretty long. I think what we have tried to do here is provide you a few broad categories, but again, with an understanding that that list is pretty long and comprehensive. So obviously we have the like kind of a public use files, which are kind of your census data and the American Community Survey. So basically these data files publicly available, you go and download, and basically you can look at the change in demographics, and that type of thing over time. I would also say like there has been really good resources that have put into developing some of the dashboards, and I have listed a few here. And what they are is basically those are just a point and click system where you want to look at what is the rate of brain injury for adults over age 65 and above, and what are the primary reasons why they are getting brain injury. So if that's a research question, you would basically look at one of the dashboards that Centers for Disease Control and Prevention, or CDC, has developed. It's called as Whisker, and then you can just look at the trend of like, brain injury among that age group, 65 and above, and what is the primary reason for brain injury. The one that I use all the time is called as the AHRQ, or the Agency for Healthcare Research and Quality, the Healthcare Cost and Utilization Project. And this is a really nice tool where you can really look at, say, a 20 or 25-year trend, and how access to a certain care has changed. So basically, a lot of my work involves related to where individuals get discharged to after their acute hospitalization. And I think this is something where you can look at the rate of going to, like, say, inpatient rehab after a brain injury, and you can really plot those trends for the last 15 to 20 years. We at VCU, the TBI model system, also have kind of a dashboard that some of the investigator has developed, actually, to really look at kind of the recruitment and all that. So again, a very effective tool that we are also using locally as part of the TBI model system. So the next category is the survey data, and BRFAS or the behavioral risk factor surveillance system. It's kind of one of the oldest kind of the survey, which is kind of a lot of folks, especially in public health, they use for the research purposes. One of the comprehensive longitudinal survey data that is available in the context of brain injury is the traumatic brain injury model system, or the TBI model system. And so Laura will be talking about our TBI model system and basically providing you some more description about it. The clinical registry data is also very useful. So we use something called as a National Trauma Data Bank at VCU. We just recently had a publication using that particular clinical registry, where we look at again, discharge destination or discharge disposition for individuals with brain injury across like 6-year time span. The one that we have used as part of this contract is called as VISTER, or it's a Virginia statewide trauma registry. So which I'll be spending a couple of minutes just talking about what that is and what are some of the findings. As Commissioner Hayfield mentioned, administrative claims data is kind of what I do. A lot of my work actually is based on using some of those data sets, which includes your Medicare, Medicaid, or commercial claims data. And as part of this contract, we have used something called as the Virginia all-payer claims data, or we call it VA-APCD data in short, which basically comprise of claims from Medicare, Medicaid, and commercial. So basically, I'll have a couple of slides just talking about how we have used that data for this particular contract. There has been some initiatives recently in terms of linkages, especially like linking like survey data with claims data. And so I have provided a couple of examples in there. But I think that is where I think there is just tremendous opportunity, for us both as a scientific field, as a provider, is how we actually linkage, or how we link these different data resources to make them kind of a comprehensive set of data sets where we can really look at the whole trajectory of care, some of the outcomes, but also can really incorporate some of the individual level outcomes or individual level data points. So I'll be talking about that when we discuss the whole harmonization and linkage. But I think as I said, this is where I think there is a tremendous opportunity actually for us to move into. I guess the same goes for like a clinical registry data, and especially with cancer research, the National Cancer Institute or the NCI has really provided resources and funds to really do some of these linkages. And as part of that, there is a pretty comprehensive data source which is called as the SEER data. It's a surveillance epidemiology and end results program, and that clinical registry can be linked with Medicare claims or some of the claims data. So again, I think similar to some of the longitudinal survey, this is also where I think it's a great opportunity for us to move into. And obviously, electronic health record and how that are being used. It is getting very popular. Obviously, we are doing some of that work both at the VCU as well as the Sheltering Arms Institute, as well as with our local VA. And I think that is actually also a pretty good resource that can provide a lot of information and a lot of insight, not just about the patient level outcomes, but also about the care that we are providing and how can we use some of that real time to really improve the quality of care that we are providing to individuals with disabilities. I think the next category is the data repository, and I think in the context of brain injury, one of the most comprehensive data repository is something called as the FITBR, which is the Federal Interagency Traumatic Brain Injury Research Informatics System. So pretty long name, but it's a very comprehensive data repository system. As I said, I just took a screenshot of that a couple of weeks back as I was putting the slides together. And on your left, you can really see, it basically provides different filtering option, what type of studies that you want to be part of this, and as I said, it's a pretty comprehensive information or a very comprehensive data source that you can access to that is relevant to brain injury. And lastly, the Icpsr or the Inter-University Consortium for Political and Social Research. I have worked with them for a few years, where we develop a disability-specific data archive platform. So Icpsr is another one of those data repository which is very comprehensive. The data that gets deposited there goes through a very comprehensive, kind of a evaluation process to make sure all the information is accurate. The data dictionary reflects what the data points are all about, and things like that. So again, I think you can actually just put in a search result like a brain injury, and it basically populates all the data sets which has variables related to brain injury. So look into that. As I said, it's a very comprehensive resource for brain injury as well as for some of the other conditions. I think the next thing that we would like to spend, I would say like next 5 to 10 minutes, just talking about some of the data sets that we have used as part of the contract. As I said, there are 4. So I'm actually going to be talking about 3, and then Laura will be presenting on the TBI model system. Again, as a reminder, this is by no means this is a deeper dive or a deep dive into these data sets, because if you really want to do that, we basically really need to have a webinar devoted to each and every of those data set. And basically considering we don't have that much time, what I'm going to do is basically just talk about what these data sources are, and just provide you like one table or one figure that is actually associated or that we were able to produce using these data sets. As I said, by no means it's a comprehensive information, but this is just a snapshot of what we have done as part of this contract using these data sources. I won't go into too much detail with these next two slides because I'm actually talking about each of these data sources in detail, but this is just a snapshot of how these four data set looks like. As I mentioned before, the VISTER is kind of a trauma or a clinical registry, which is actually maintained by the Virginia Department of Health. And basically, you can really look at information specific to brain injury. The all-payer claims data is also kind of maintained by Virginia Department of Health. However, the Virginia Health Information, they are the contractor who actually provide access to the data. And it has Medicare, and commercial claims. The traumatic brain injury or the model system or the TBI model system, Laura will be talking about that, but it's a longitudinal survey, very comprehensive information, not just at one point, but there is a several follow-up time points. So again, really a strength of this particular study is it's the longitudinal aspect where you can really look at how a particular individual with brain injury, how that person is moving through different systems, how their outcomes are changing, and things like that. So as I said, very, very comprehensive information. And the fourth one is the RSA data, which is the Rehabilitation Services Administration data. It's all employment specific, maintained by the Department of Education. And then you can really use that data to look at initiation of services and whether that person was able to achieve outcomes, in terms of employment in a given time period. So just quickly going through these data sets, as I said, VISTER or the Virginia Statewide Trauma Registry. That's a reporting platform. So basically, all admissions in the Commonwealth, which results into hospitalization, and basically which are because of the ICD codes that I have listed there, that goes into the clinical registry. It also includes if a person is getting transferred from one hospital to other, and it also accounts for in-hospital mortality. So as I said, how we have really used that data in several different ways. And what I'm just going to show you is just like one table from the registry, and which is related to discharge destination or where folks with brain injury are discharged to after their acute hospitalization. So this data is coming from 3 years, 2017 to 19. Again, I'm not going to go through all the numbers and all the percent there. However, if I would want to highlight one thing, I would really look at those 50%. I think it's towards the end of the table, which is kind of really kind of surprising finding. It's like a pretty high number of individuals are actually getting no further care after their acute hospitalization. The RSA data sets or the Rehabilitation Services Administration data, as I said, it's collected by the vocational rehabilitation agencies for each state. The data that we have used for this particular contract, it's actually from two time periods, 2014 to 16 and 2017 to 18. It has several really interesting variables, in addition to demographics and education level, and those are your outcomes. So where, initiation of services, as well as, there is an outcome, which is employment, whether a person was able to achieve employment within a certain time period. So again, just showing you one figure, among everything that we have done with that particular data, and which is actually the next slide, and it's just showing kind of state level variation in terms of like how people with disability, especially with brain injury, how they achieve the employment within 90 days at all these states. And these are kind of all adjusted results. That means we adjusted for both the individual level characteristics as well as some of the state level characteristics, such as the unemployment rate, state's GDP, and all that. Again, not going into too much detail, but this is what we have been using the RSA data for. And there is a publication in kind of preparation, which hopefully will be submitted next month. I think the next one, which we are very fortunate to have received additional funding from the CNI, the Commonwealth Neurotrauma Initiative, to really continue this work using the all-payer claims data. It's a very comprehensive data set, about 4.5 million individuals in the Commonwealth, Medicare, Medicaid, as well as commercial claims. And for this particular contract, next slide, please, Laura. What we have done is, among just showing like different conditions, and we have also looked into this data to really see like where these individuals live in, and then basically and so basically two graphs. This is divided by the health district. The top one are kind of the raw, and then kind of the bottom one is where we adjusted for the population in that health district. And where we can just see, right, like some of the health district higher rate, higher prevalence of TBI, and I guess the subsequent or the next steps are also look at the access to resources as well as care that is provided at these health districts. So I guess one of the other really important study that is going on at VCU and the VA is what we call as the limbic and sensi. And again, this is another longitudinal study that we are doing with service members and veterans with brain injury at both VCU and VA. And this is right now 2,000 plus individual. Again, the target is 3,000. It's a prospective longitudinal study. So again, very robust study design. Each individual is have follow-up, multiple follow-ups. However, in addition to some of the self-report and some of the assessment data, we are also looking at some of the biomarkers, and there are some neuroimaging studies that are part of this. One of the other thing which I am actually involved in is we are also linking some of these to kind of a claims data, the VA claims data and all that, where we can really look at access to care and utilization of services and all that. So this is just a map, just showing the recruitment side for the study and who is doing what. This is also available on the Limbic Sensi website if you are interested in exploring more about it. So I'll let Laura talk about the BCI TBI model system. Laura?
Yeah, hi, welcome everybody. So first, just to talk a little bit about the TBI model system. It's a data-driven advancements based on research findings, hoping to help all people affected by brain injury. We have we look at advancements for inpatient rehabilitation practices and coordination of care and preparation for discharge transitions. We also strive towards caregiver support and advocacy based on stakeholder feedback advising for the inclusion of caregivers from day one to improve communications and the coordination of care. We also look at improved access to care and removal of barriers to research participation. A little bit about that is, looking to be as accessible as possible. We're currently expanding our translation services to get the best picture of Virginia TBI as possible. So in the VCU TBI Model Systems grant, the current aims, we've been continuously funded since 1987. So we have about 3 decades worth of data that we can look at and hope to answer questions. We're currently funded between 2017 and 2022. We're in the process of our grant applications coming up. So, we're hoping to continue this work for as long as possible. And we're currently consenting about 35 new participants a year. So as you can see, that is a lot of people after 30 years with 35 a year. Form 1 is our first step where we look at inpatient data as well as a pre-injury questionnaire and look through some medical records in order to abstract for the Form 1. We have Form 2 follow-ups, which Amal touched on. Those are our longitudinal survey follow-ups, which are done at this point after COVID, mostly over the phone. We had a driving module where we looked at return to driving and barriers there. That just wrapped up. A caregiver resilience module in which we ask caregivers if their needs were met and how can we better meet those needs as a module site-specific project. We're currently still in process of the chronic pain survey, in which we are talking to participants about their experience with pain since their TBI in hopes that we can help better treat that pain. The resilience and adjustment intervention is a site-specific project we're doing as therapeutic intervention done by our PsyDs, Anna Mills and Nancy Sue, that is looking at a therapeutic intervention that can better support resilience and adjustment after brain injury. So this is that chart that he mentioned earlier. It can show a little bit of a dashboard of our numbers as of yet. The reason someone might no longer be active is either if the participant expired or if they asked to withdraw. So that's where you get that number of total versus active. I won't go into this too much, but as you can see, as of now, we have had at least 38 follow-ups that are 30 years out of injury. So it's a pretty big feat to be able to follow people for about that long. So we follow people at year 1 after injury, year 2 after injury, year 5, 10, 15, and then every 5 year thereafter. We also have here at VCU, the Richmond through VCU is the Richmond VA Polytrauma Rehabilitation Model Rehabilitation Center, the PRC TBIMS model. That's through a connection with the VA here in Virginia. It was established in 2008 through a congressional mandate, partnered with the other NIDLR programs, and there are currently 5 sites included in the study, including the one here in Richmond. It also, unlike the TBI model systems, they also include MTBI or mild TBI, whereas we only look at moderate to severe. And they have more military/veteran specific variables that we don't ask in the model system, in the VCU model systems project. So like the model VCU model systems project, there's some baseline data collected at the time of enrollment, and again, follow-ups at year 1, 2, 5, 10, 15, and every 5 year thereafter. Their current enrollment system-wide is about 1,600, and Richmond specific is about 316. And in the fiscal year 21 of data collection, there were 38 new enrollments, and about 78 follow-ups. So through this grant work with DARS, we also wanted to look at an opioid-specific project. So I'm sure you all are familiar with the opioid epidemic that everyone was talking about before COVID became the hot button issue. So we were looking at opioid use and misuse within the traumatic brain injury population, specifically in Virginia, and seeing if we could get a better picture of that. So a little bit of background, we know from the CDC that about 136 people die every day from an opioid overdose. About 70% of the deaths in 2019 involved an opioid. Knowing that people with brain injury are likely prescribed opioids or use opioids while they're inpatient, we want to know, what does this look like specifically in that TBI population? And what could this better picture that we gain, how can that help us provide the foundation for better outcomes? So for this study, we used a confidential survey. One thing that I'm highlighting here is we had specific IRB, because it's a confidential survey that we did through REDCap. One of the things that we had to determine, given our population, is the determination of cognitive eligibility for, quote, decisionally impaired adults. So how we kind of met that obstacle was by doing some questions that look specifically at participants' understanding of what survey research is, what we're using it for, and whether or not they understand that it is voluntary. So for before they got down to the actual study questions, they had to answer these. If they did not pass, they just didn't do the survey. And if they did, we were able to move forward. We also used the DAST-10. So the DAST is a drug and alcohol screening test that has since been adapted to be about 10 questions long. We contacted the creator, Harvey Skinner, and asked if it was okay that we adapted it to look at opioids specifically. So we did adapt that as well. One of the best things in terms of the methods used for this survey is that we partnered up with the community partners of DARS and BIAV, as well as some of our other community partners, to help us disseminate this survey. And we were able to get quite a lot of traffic on that, even despite the COVID-19 disruption. I'm sure a little bit of that was people looking for something to do at the beginning of the pandemic, but we were very thankful. So as you can see through the dissemination practices, we had about 45 people that answered that they heard about this survey through BIAV, and about 6 people specifically said DARS, though I'm sure there were more that were included in there. And a lot of these surveys were done kind of at the end of a model systems Form 2 follow-up survey. We just kind of rolled straight into this survey. So that's why you see a lot of it coming from the model systems. Just one little bit of data there. We had, based on one of our questions, over 65% of those that responded to this survey were at one point prescribed an opioid, which we know is likely for that population. But what was interesting is asking for those participants that took an opioid that wasn't prescribed to them in the last year, how did they receive it? And so we see mostly people were given them by a friend or a loved one. Some people had bought them from friends, dealers, online, and a lot of people had other methods. And then we're back to Amal.
Thanks, Laura, for the really nice overview. I think one thing that I would like to add here is, even though we are talking and thinking about different data sources and how we can integrate them and link them. I mean, one thing that we really also need to think about that there are instances where we really need to collect some of the data, which is actually a really good example of what Laura has presented. I mean, that information didn't exist actually a couple of years back. And I think that particular survey has really kind of provided that information related to opioid use and among like individuals with brain injury. So I think for the next 10 minutes, my plan is to actually just wrap up the presentation. But before I do so, I really want to highlight or talk about 2 really important things. and one of them is the social determinants of health, um, or the social risk factors, um, or the social variables. You must have seen like all these different variation in terms of like what are they referred to. So obviously, for individuals with brain injury, or I would say individuals with disabilities, I mean, the social risk factors or the social determinants of health can really have like a compounding effect, right? I mean, I think it can really limits access to utilization of services and access to care, also impact the long-term health outcomes, as well as community participation. And with the COVID pandemic, one of the things that we have realized is really that impact can really be exacerbated, right? Because the impact is instantaneous, because there is just a lack of buffer for individuals with disabilities, those who have these social risk factors. The process lasts longer, or the effect lasts longer, and the recovery process is really slower. And basically that really makes individuals with disability who have social risk factor are more susceptible for the next shock, or when the next disruption is going to happen. So again, I think there has been a lot of talks about the economical recovery after the pandemic, and people are throwing all these alphabets in there, where how the recovery will looks like, whether it's kind of the V-shaped recovery, or U-shaped recovery, or the K-shaped recovery. And I think more I was reading and kind of listening to that, I'm like, yeah, I think this is actually very relevant when we talk about, say, access to care or utilization of services. I mean, we all know there has been just a tremendous disruption in how individuals with disability access and their access to care, as a result of pandemic, and how that recovery is going to look like when hopefully the pandemic is over in near future. And I kind of try to plot kind of a modified K-shaped diagram there, where kind of a green line represents after the pandemic is over, kind of maybe a steady increase in access to care, and that's going to have positive impact on health outcomes and participation and things like that. With brain injury, individuals with brain injury, obviously that disruption is going to continue, but hopefully a recovery over time. However, when we talk about the compounding effect, obviously the disruption was more significant, and that recovery is going to be much slower, and may never be reach where it should have been, before the whole disruption began. So as I said, I mean, really think about the social determinants of health or social risk factors from that context, and why it's really important to measure those or look at those as we are utilizing several of these data sources. The Institute of Medicine, or now it's called the National Academic of Science, Engineering, and Medicine, a couple of years back, I would say in 2016, has released a very comprehensive report on social risk factors. And again, I think their purpose for releasing this report is, with this whole value-based payment, and as the payment models are changing. But I felt like that information is very relevant as we are talking about the social determinants of health, especially using data for brain injury or other population. And this is kind of a conceptual model, or the conceptual framework that they have proposed, where they have shown kind of how these different social risk factors can really impact access to care, and can have like kind of impact in long run, whether it's utilization of services, its health outcomes or the resources that they are using. Again, we really don't have a lot of time, but as you are thinking about the social determinants of health in your context, think about that, how these factors interact with each other, how cumulatively they interact with the health system or with the community-based services, and altogether how that has an impact on someone's long-term health outcomes, whether it's employment, whether it's participation, whether it's health and function. The report has also indicated data. Yeah, next slide, please, Laura. Yeah, thanks. The report has also indicated kind of what kind of data is available. Again, as I said, this has been done in 2016, so there has been some updates, but still, I think there are a lot of things which are still missing when it comes to the data availability, whether it's transportation, whether it's a food insecurity, and whether it's something that we have been working with DARS, which is the housing issue, or especially the stable housing. So those are like really important. We all know how much impact they have. Again, like how they are getting captured in some of these data sets, and how they are represented. I think it's that system is still not perfect, but definitely an opportunity to really work on that. I think the last thing that I want to talk about is this whole idea of data linkage, integration, and harmonization. And again, I think I kind of I have put all these things here with a complete understanding. These topics by themselves is kind of, as I said, like a hour-long kind of webinar. But as we are thinking about data with brain injuries, some other patient population, we actually really need to think about these things, because they really impact how we look at the data and how we utilize it. So as I mentioned before, I think where the opportunity is for us as a research community, as providers, as advocacy group, is to really start thinking about how can we leverage some of these data sets, not by themselves, but really when we really integrate or when we really link these data sets with other. And I think the example I have given before is some of these survey data, whether it's the Tbi Model System or whether it's some of the clinical registry data. By itself, those data sets are rich, provides really comprehensive longitudinal information. But how can we really leverage on that? I mean, how can we further extend the value of those data sets by linking with, say, for example, like a claims data, right? Where we say like, okay, in between that follow-up that we are doing as part of the longitudinal survey, individuals with brain injury, actually, they go through like different health providers, they utilize a lot of resources, and how can we really capture that? How can we really leverage, what we have been already collecting, and by just linking it with some of the other data set. As I mentioned before, this whole idea of like, the context or environment, I mean, it's so important, and as a rehab and disability, community, we always have known how important they are. However, how can you again leverage on that? I mean, how can you use some of the publicly available data set, which I mentioned before, the census data or the American Community Survey and things like that? And how can you really look at some of the community level resources? So as I mentioned before, we are actually continuing to work, using the all-payer claims data, and we are very fortunate to receive some additional funding to continue that work. And this is kind of the framework that we will be actually operating with as part of next few years, working on some of these data sets. I guess the next thing is which is pretty important is this whole idea of data harmonization. Next slide. Yep. Again, the same idea where how can we really utilize all these different data sets. So in Virginia, in Commonwealth, we have a newly formed Office of Data Governance and Analytics. And I think in one of our regular meetings, Donna actually mentioned this to us, and she's like, "Hey, do you guys know? We have a new office, and they're actually working on some of these things." And every time I actually visit the portal, there is additional stuff. So I just feel like there is a tremendous opportunity, especially a lot of you who are on webinar are actually working in like a state departments, kind of like a DARS or equivalent in your state. And I think this is kind of a really great opportunity for us to work with some of these state agencies to think about how can we really include some of the data sets that are relevant to brain injury, that are relevant to spinal cord injury, because the infrastructure is there, the resources are getting placed, and I think it just matter of us engaging, with an office like this, and really making sure the data sets that deals with or that looks into individuals with disabilities are well represented in all these portals. Because I think there will be a really great value if those are here and again are supported by some of the infrastructure development plans that are happening. I would say especially in Virginia, but I'm pretty sure they're happening across the country. So where do we go next? I mean, we listed a lot of things. We were able to do a lot of things as part of the contract. I think our next step as part of this particular contract is something called as a data plan. And what that data plan is going to be is basically it will be a very comprehensive report of everything that we have. Laura, next slide, please. Thanks. Yeah, so the data plan is going to be a comprehensive report of the results and finding from all these different data sets. We'll be presenting pretty extensively, the social determinants of health, why they are important, things like that. We have a very detailed plan about some of the data linkages and some of the harmonization. And really most important thing is like, how can we place ourselves to be engaged with some of the individuals at state level. I think to me, that is really the key, like where we can actually take some of these things to the next level. So obviously this webinar is part of some of the dissemination efforts that we are doing. But obviously there are scientific publications and some other presentations that we have done or we plan to do as part of that particular project. Our plan is to finalize the data plan, and hopefully it will be available for everyone to look at it and hopefully use it for some of the work that you are doing. I would say towards the end of July of this year. So I think we are really excited about that and the products that is getting developed as part of this program. So just to summarize what we've been talking so far. Next slide, please, Laura. I think these are just like I would say some of the take-home points for this webinar, and I think the things that we've been doing as part of the contract. I think the most important thing is like really understanding the data source. I mean, as I mentioned before, no data is perfect, or no data are perfect. There are limitations. However, I think you just need to acknowledge some of those limitations. And I think one of the saying is, don't let perfect be the enemy of good. And I would say it's kind of very applicable here, because I think, we have just a lot of room for improvement and making some of the changes. I think we just need to get started on some of these things. To us, the relevant and meaningful, both clinically meaningful as well as policy-wise meaningful questions, those are really important. I mean, I often tell people that, I think we don't do like data mining. I don't think I'm actually I don't even know how to do data mining. And I think it's a pretty different discipline. I think, there are people actually who do a lot of complicated and sophisticated things. What I like to do, and I think what we should be thinking is, some of these questions, and then really approaching these different data sets with those questions. And I think, to me, the products and the engagement is going to be very meaningful if we do that, rather than letting the data dictates our research question and what we want to study. I think the third thing, which I think we've been actually really talking a whole lot in this particular presentation, is really engagement of everyone. I mean, we have a common goal, which is really to improve community participation, and as Commissioner Hayfield said, really to improve quality of life for individuals with brain injury, with individuals with spinal cord injury, and individuals with disability. I mean, that's kind of our common goal. I think where we get caught up is, we actually kind of make ourselves siloed. Oh yeah, I'm an academic researcher, I'm a faculty person. So, I think that this is what I need to do. I need to generate publications, and, that's it. I don't need to worry about other things. But I think, the use of data set and a data platform, to me, why this is exciting, because it really provides that common platform where I can really talk to my colleagues and my partners in health systems who are clinicians and providers. But I can also talk to like DARS. I mean, I can talk to Chris, Donna, Commissioner Hayfield about several of these things. I can also talk to BIV and United Spinal, which I often do actually, about some of the issues that they are working with. So I think it really provides that platform for us to really work together for some of these common goals I have mentioned. I think it also provides us the opportunity as the academic researcher to also talk to the grant and funding agencies and say, hey, these are some of the important things, and the end product should be, in addition to publications and scientific presentation, it also needs to be some of the dissemination to the community and to the stakeholder. And how can we really translate whatever we have learned through the process to everyone who is involved in this. The IOM, or the National Academics, recently released a really comprehensive report, which is called Less Traumatic Brain Injury, a Roadmap for Accelerating Progress. And this infographics, I mean, it's directly coming from that. And this is really kind of what we have started, right? I mean, the journey for someone with brain injury is kind of going through different systems and all that. Results into data, and like how can we really look at that together to really improve the kind of a long-term health outcomes for individuals with disabilities. And I think I'll just end on a lighter note, and which is basically I had 2 young kids, and they're very good at actually solving puzzles. And I have always wondered like why. Like, what are some of the strategies they are using actually to, solve the puzzle? And so I independently asked both of them, I'm like, how you guys do this? I mean, how you guys are getting better every time I give you more complex puzzle? And I think obviously they gave me some different answer, but one of the things that they both mentioned about is really looking at big picture, like really looking at kind of what is the thing that they are trying to solve. The picture that you usually have with the puzzle set, and really looking at that first, and then approaching kind of those puzzle pieces. And I think to me, it makes perfect sense. When I was putting these slides together, I mean, I guess, as a community of researchers and advocacy and other stakeholders, we just need to really look at big picture, which is really improving participation and quality of life for individuals with disabilities and with brain injury. So I think I'll just stop there. As I said, these are our email ID. And if there are any follow-up questions that we are not able to cover in Q&A session today, feel free to reach out. So thank you very much.
Thank you so much, Dr. Carmarker and Ms. Albert. We really, really appreciate it. I can certainly say from direct experience that we have learned a lot from you and your team about how we could do better at sharing and using data. And I just love that you took us from data as maybe a headline to data that can tell us a full story that is going to inform us and take us on a journey. And as you so passionately have said to me many, many times before, because it is important that we use this data to help improve the outcomes for people living with brain injury and their families. Now, we do have a number of questions in the chat, so I'm going to go ahead and jump in. I might take this first one, Dr. Carmarker, because they get more complex after that. But if I can just get my thing to screen. One of the first questions that came in had to do with registries and whether or not every state has a registry, a brain injury registry. Not every state does, but I am just now putting a link in the chat to a white paper that was completed by the federal grantees as well as NASHA, the National Association of State Head Injury Administrators. Maria Crowley, from Alabama, who had to jump off the call a little bit earlier, is the person that put that together. But within that document, you will see a listing of the states that do have registries and more information about that. You, Dr. Carmarker, have you done an analysis of outcomes for TBI patients based on duration of their rehabilitation, comparing outcomes for people on Medicare, which has no cap on rehab since 2018, versus people on commercial plans, which do have therapy caps?
I mean, I don't think we have answered that particular question. We have certainly looked at stroke where we have actually compared, Medicare versus commercial and all that. But I mean, that's a great point. I think, that definitely can be done. Haven't done so far, but, again, I think that's a really excellent point where we can really look at how they differ and all that. So as I said, we have done it for stroke and couple of conditions, not with traumatic brain injury yet, but we can definitely look into that. So thanks.
We've also there's also a question: are the Virginia State Trauma Registry and similar registries publicly available? If not, how are they accessed?
Yeah, I think the visitor, I mean, there is actually kind of the process that you need to go through. I mean, if you follow the link, I guess like Chris, you were putting a couple of links in there, but I assume everyone will have access to the slide deck as well. So I think if you follow through the link, there is actually a process like how you can get access to it. So I mean, you can access that way.
There are some differences depending on if you're requesting with PHI or not. It's easier to get them to give you the data if there's no PHI involved. As far as, because I think I saw in the questions, they also asked specifically about the TBI Model Systems project. So all of our data for the TBI Model Systems nationally is housed by Craig Hospital and the NDSC, the National Data Statistical Center. So TBI NDC, they have a link on their website for data requests. And whether you're an outside researcher or internally a researcher from the model systems that's just requesting the data for use and analysis.
Those are the current, oh, let me see, 2 more questions just came. Okay, are there other, if you have questions, and sorry, I can't read and talk at the same time, obviously. Can this information be a resource for an organization's website to download? We will be providing you with copies of the slide deck and the recording of this presentation. So we will be sending that out to all the attendees over the next 24 to 48 hours. So, are there other questions that you might have and the audience has? Was there any analysis of any of the data you viewed relative to the patient?
I did not understand that question. So, oh, okay. Yeah. I mean, we have, so we actually look at, yep. Yeah, so we actually control for or adjusted for a lot of those things. So obviously, like Icpsr or the Virginia Registry, the Statewide Trauma Registry has some of that information. And I think, as I said, one of the recently published paper, which I can actually put in the chat or maybe can email that to you, Chris, later this afternoon, where we have looked at like all those things and kind of how that impacts, discharge destination and, that type of thing. It's using the National Trauma Data Bank for individuals with brain injury. So
Ann's going to ask as well, her follow-up question, will those results be shared? The IAV wants to know.
Yeah, I think, all that will be part of the data plan. So, and as I said, one of the recently published manuscript, again, that's in public domain. So yes, that's a plan.
Are there other questions? You can put them just Q&A. So April Turner from Alabama asks, for the opioid use section, was the other section so large due to individuals not wanting to answer? What is your guess on where they got the opioids from?
So the other, what you also have to understand is sometimes it includes a write-in section so that you can maybe collapse answers into their respective things if they chose to write it in. It could be due to that. I couldn't say if they didn't write in where they got it and they just left it blank and said other. One of my craziest answers crazy is not the right word. One of my most wildest answers was a participant who reported that they had robbed a pharmacy in order to obtain the opioids. So that one ended up being other, even though obviously that's a standout answer. But, that could be, they could have found them. They could, there's a bunch of different things of what other could be. And I'd have to go back and look at some of that write-in answer, but a lot of it was just an other.
Shows you a lot about the impact of opioid addiction. So
right, exactly. And if you have that combined with prefrontal cortex damage, then your impaired decision making on both sides of that scale is going to be different.
We'll have about 5 minutes. Any other questions or any comments? Megan Simpson is asking, did you ask if they had addiction before their traumatic brain injury?
For this survey, we were more concerned with use before. Some people did reveal that just in chatting, but likely if there is history of opioid use disorder or substance use disorder, even in hospital, a doctor is likely not going to be using those if they have a documented history of opioid use and misuse, or misuse specifically.
And as Chris said, and I just put the citation for the paper I was talking about in the chat. So,
and I am going to link here is the link for if you wanted to request the data set from the TBI model systems.
Thank you.
Mm-hmm.
Lori Chalmers is asking, do you have tips on getting demographic information during active phone calls without sounding robotic? What an good question.
Phone calls with whom? With potential participants?
I believe so.
So demographic information, it is hard to collect that without sounding like you're a rote survey form. But, you know, in terms of getting their address and stuff, be like, for future reuse, if I need to contact you, you can ask that way. It's just what racial group or groups do you identify as, and then I'm not sure if there's a way to not do it sounding non-robotic. Yeah, I'm not sure. Amal, do you have any suggestions?
You can see in the chat, Ann McDonald from BIAV is saying that they explain it, that they need it for understanding what folks need and where they are. That's a great way to put it. Yvonne Peterson's asking, do you know when the data request form will be available? The one for the registry and one for the model systems information is in the chat right now. Both, there are two separate links for those. Any other questions, or we have just 1 or 2 minutes left, or anything you all want to share about your experiences in data from multiple sources, especially around people with brain injury? While we're just taking this last minute to in case there's any questions. Oh, Debbie Hall asks, how do we obtain access to the final report when available? We will be publishing that, and we will make note to send it out to the attendees of this webinar, since you were kind enough to join us today. As you log off from today's webinar, you will be seeing a survey. I hope you will give us your honest feedback about today's webinar. I want to again thank Dr. Amal Carmarker and Laura Albert. Working with you both on this project has so broadened my own thinking on ways to use data and the benefits for people living with brain injury. I repeatedly come back to something Dr. Carmarker has said to me, and that is that there's value in looking at data from one source, but it provides only one perspective and may result in inaccurate presumptions. By sharing data, we can improve services, inform advocacy, change policies. We've seen all that happen in Virginia in just the last 6 months in so many different ways, and we are so grateful for your work and how it's going to inform what we're able to do in the coming years. Double check.
Thank you, Chris. We really appreciate all the support, and really excited to be part of this this work with DARS. So thank you.
Thank you all for spending your lunch hour, or depending on where you are, maybe your breakfast time with us. And please don't forget to give us feedback on the survey. And have a good day.
Thank you. Bye-bye.
Thank you.
Thank
Nice
you,
job,
Dr.
Chris.
Thanks, Commissioner Hayfield, for being here. We appreciate it.
It was good information. Signing off.
All right, Donna, thanks for all the behind the scenes work. Much appreciated.
All right, I'm going to go ahead and shut it down.
Okay, thanks, Donna.